All right, good evening. This is Bruce Boland. I would like to thank all of you who have signed in to this evening's educational webinar on the Society of Thoracic Surgeons Adult Cardiac Surgery Database. I'll make a few introductory statements as more people sign in. I'm chair of the SCA Quality and Safety Leadership Committee in the SCA Database Committee, which is chaired by Dr. Miklos Kurtai, is a subcommittee of the Quality, Safety, and Leadership Committee. The SCA has partnered with the Society of Thoracic Surgeons for a long time. This relationship grew a little bit more in 2013 when the SCA and STS partnered to develop an anesthesiology subsection of the adult cardiac surgery database. I feel that this relationship is very important, and I feel it's very important for cardiac anesthesiologists to have a good understanding of the complete cardiac surgery, the adult cardiac surgery database, of which the anesthesiology subsection is a small part. As one of my cardiac surgery states, the STS adult cardiac surgery database is their lifeblood for working on quality initiatives at the local level. And if cardiac anesthesiologists are going to interact and be involved with their cardiac surgeons, their cardiac team, and quality measures, understand if they need to perhaps apply practice advisories that are developed by the SCA or other societies, understanding of how to utilize the STS adult cardiac surgery database is very, very important. So that was the reason for developing this educational webinar. We have sent out to you all in the emails, you should have an attachment of the version 4.2, which just came out on July 1st of this year, of the STS adult cardiac surgery database. And also an attachment of the STS training manual, which gives all the definitions of how they define everything in the database. This is very important for all adult cardiac anesthesiologists and for fellows in cardiac anesthesiology training fellowships, I believe will be very helpful. I would like to thank Mary Lunn and Jim Pavletich of the Veritas Management Company, which is the SCA management company, for coordinating this with the Society of Thoracic Surgeons. And I would like to thank Carol Crone for taking her time and allowing in the STS for developing this webinar. At this point in time, I would like to hand the microphone over to Dr. Miklos Kurtai. Thank you very much.
Good evening, everybody, and Bruce, thank you very much for the nice introduction. So tonight's session will be chaired and moderated by myself and Carol Crone from STS, who is the National Database Manager. And I also would like to invite the other members of the STS team to actually quickly introduce themselves to the rest of the group, and then we can take it from there. Carol, would you like to go ahead and introduce yourself?
Oh, sure.
And the panelists can do so too?
Yes, thank you. My name is Carol Crone, and I'm the Senior Clinical Manager over the databases. I've been with STS for a little over almost 4 years now. Happy to thank you so much for inviting me to give this presentation, and I hope it's educational, and looking forward to any questions we receive afterwards. Leanne. That's Leanne Jones. She's the database manager for general thoracic and congenital databases, and she'll be helping moderate or helping manage this webinar as we go forward. And we have Derek Steck. Derek Steck.
I'm Derek.
Derek Steck is the contracts manager for the database. If there's any questions related to site contracts, or if you are interested in joining the anesthesia portion and your site already is not participating, Derek will be the person best to answer those questions for you. And we also have Jane Hahn on the line with us, who is the Associate Director for Quality of the national databases, and any operational questions, she'd be able to answer those for you as well. Thank you, Dr. Kurtai.
Thank you, Carol. Are we okay to proceed?
Sure, yep.
Okay, please.
Okay, so thanks again for having me, Dr. Boland and Dr. Kurtai. We're going to take a look at the history of the STS database and the anesthesia, our partnership with the SCA. The Adult Cardiac Database for the STS was the first database that the STS birthed, and we were inaugurated in 1989 as a response to some quality initiatives that came out of the government and looking at unadjusted outcomes and showing poor results for cardiac surgery. In response, the STS put together the Adult Cardiac Database and quickly came up with some risk adjustment for cases, so we're able to compare apples to apples and give the surgeons and cardiologists a true representation of the elevated risk of the patients that they were caring for. In 2013, the STS and SCA partnered together and developed an anesthesia module, which was a separate module and is voluntary participation for sites who participate in the STS, also wanting to submit additional anesthesia data to what was already collected in the STS database. These data are used for benchmarking of the anesthesiology patients, and it is compared to other anesthesiology programs across the country. The anesthesia module in 2017 was then merged into the Adult Cardiac Database. It's still an optional component, but it's better linked now with the patients that the anesthesia sections are being completed on. And then in 2020, we've undergone a major upgrade to the entire adult cardiac surgery database, including the anesthesia section. We'll go through that shortly. It is in the link that Mary had sent out in the invite for the data collection form, but we will walk through that form so you can see all of the cool stuff that's collected in there and get ideas for some research projects and how we can improve the care of the cardiac surgery patient throughout the whole course, including the anesthesia portion of their stay. First, just an overview of what is the Adult Cardiac Database. We have more than 7 million records, procedural records in the database, which leads to a lot of research and a lot of quality improvement opportunities. We have over 1,000 national and international sites. 70 of those sites are now participating in the anesthesia section. It constitutes 2,900 surgeons and 772 anesthesiologists. We release quarterly benchmarked reports. Twice yearly, we release a start reading report, which is used for voluntary public reporting. Both of these, all of the quarterly reports include the STS-like and the STS national numbers for your site to see where you're falling compared to other like groups, which includes the type of program, if it's an educational program with fellowship, or if it's a community hospital type program versus the educational programs. And then it also looks at volumes of cases. The wonderful thing about the Adult Cardiac Database and the anesthesia section is that we standardize data collection and data definitions for this specialty. We are working with our informatics task force so we can become more standardized with EHR definitions and look forward to implementing some type of automatic abstraction in the future for more variables than what we do now. The STS, when your site submits data to the STS, you have a data manager at your site who typically, 80% of all data managers are nurses. Most have some type of background in cardiovascular, ICU, or OR experience. Probably close to 80% of those nurses then they are either still working bedside or their main job is data abstraction. They submit that data to the STS. to our warehouse, who is IQVIA. We recently partnered with IQVIA for the data warehousing function because of the technology that they bring to this specialty and to their experience working with big data. IQVIA is a leader in this field in dashboard reporting and continuous feedback, data feedback. When your data manager abstracts that data, they may have questions about it. It's important to know who your data manager is so you can work with them, ensuring that your data is accurate and complete ensures that you're getting good feedback. So when you're having QI projects at your hospital, you're able to use the most up-to-date data and make good comparisons, and knowing that your QI projects are moving forward as they're supposed to be. So they may reach out to you with questions in the anesthesia section regarding anesthesia variables, or within the operative section, perhaps a question regarding a perfusion field that they need a little help with from the anesthesia side to better understand. Your data manager then cleans up the data, make sure it's all complete, make sure the numbers are making sense. They submit that to the data warehouse. The data warehouse gathers all that data together. 4 times a year, they send a package, a virtual package of data over to DCRI, who is our data analytics center. DCRI takes that data and they perform risk adjustment on it. We have 7 risk models now, cabbage and valve, or a combination of cabbage and valve, that we look at and we adjust according to the risk that the patient enters the OR with. That those outcomes are then looked at for observed to expected ratios, and then your star ratings are developed off of those observed to expected ratios versus all of the other hospitals in the cohort. And then that data, once DCRI does all their magic, they send it back over to IQVIA for dashboard reporting. And that dashboard, we'll have 2 different dashboards. Right now we're in the process of getting our first round of data back from DCRI into the IQVIA on the benchmarked dashboard. And that dashboard will be available shortly. In addition, we're working on a longitudinal dashboard through our research center, which will contain 10 years worth of longitudinal data for, we'll be able to break it down by, I believe, as far down as quarters, to look at 10 years worth of quarters to see how you're doing with caring for your patients and providing that their patients are receiving quality care and their outcomes are satisfactory. So the major functions of our IQVIA data warehouse is that it's a 24/7 cloud-based platform, which means that your data manager can harvest and clean their data continuously. There's decreased time spent on data submission, so it does save them time compared to the historic way that we have done it in the past. You're able to drill down into cases and see exactly which patient was having a hard time in the ICU, or which patient had a poor outcome, which patient stroked. You can drill down to see exactly all of the patient's data, whoever did have a bad outcome. And then again, the longitudinal benchmarked outcomes are something that's coming in the near future. There's a real-time feedback on data quality. And then we do have an optional web-based data entry, which means your site would not need to use a third-party vendor. They could submit it right directly into the IQVIA platform. And there's no additional fees compared to the database in addition to the database participation fees that we have if you choose to do the web-based data entry. And then I just these were some QR codes I wanted to share, but I'm going to go back to this slide here first. I'm going to walk over, Dr. Kurtai, I think it's time we can walk over to the data collection form. So I'm going to do that here.
Thank you, Carol.
Okay. I'm just going to make the screen a little bit smaller and pull over the STS website for everybody.
And Carol, while you are doing that, I'd like to actually raise the awareness of our attendees that if they have any questions, they are welcome to use the Q&A function of Zoom to start sending in some questions. So at the end, we can have a lively discussion.
Yes, that would be great. If everybody could please submit your questions using the Q&A feature, we'll be able to track those questions. And if it's something we can't answer on this webinar, we would be able to have your information and email you shortly after the webinar with an answer if we need to discuss it. But we'd love to have your questions so we can answer those following this presentation. So this is the STS website at sts.org. The fourth blue tab over here is the registries tab, and we go to the STS National Database. We have 4 different registries right now. STS is also involved in the TVT registry. All of that information is housed on the ACC website, but you can find the link here if you're interested in looking for that one. It's here on the left side. The SCA participates in the Adult Cardiac Registry, and our last couple versions are posted here underneath the data collection resources. Our current version, which started in July 1st of 2020, is version 4.2. This includes OR cases, the OR dates of 7/1/2020 and beyond. Version 2.9, it takes care of OR dates from 7/1/2017 through 6/30/2020. So our new version, or updated version that just went live on July 1st, is the version where you'll see the majority of, or you'll see the anesthesia changes that were made. And let me pull that up for you here. And we're going to walk through this form. We're going to talk about the entire form because it's all very important to your site and to ensuring that your patients are receiving the best care possible. And all of these fields have an importance. The risk model variables are marked with the double asterisks, and then we also do NQF reporting for the ACSD, which is free to surgeons if they're for member surgeons, for the STS surgeons. So we have administrative section. One interesting factor here is that we have the STS related clinical trials. Currently, STS is part of the hybrid trial, and we are collecting data for that trial. It's been ongoing, I think, since 2018 or 2019. I believe 2018, and we are still collecting for that trial. And then we get into the demographic section. Basic demographic information. The society, our research center, is looking at doing geocoding. So we are collecting information on zip code, all the way down to street address to perform that geocoding. Some sites have restrictions at their hospital related to their own HIPAA rules, their HIPAA guidelines. There is no, the STS registries are all HIPAA compliant. Some sites just have internal rules that do not allow them to submit this information outside of their site. If we are able to get enough of this information, we can really look at geocoding and look at these socioeconomic factors when it relates to patients developing cardiovascular disease and how they do after surgery. Anytime we share data with anybody, it is de-identified, so we never share any PHI outside of our own internal analysis related to zip code or street address. We do capture race, and we are looking at the Black and African and Asian races have associated impact on the risk, the outcomes. So we are looking a little bit more closely at that because the society is aware of the possibility of deferring surgery for patients because of their race due to increased risk. So we're trying to help mitigate those concerns that were brought up. We also have capture ethnicity. For hospitalization, we capture your hospital MPI, your hospital information, zip code, region, the insurance types. Currently, we are working on a project in our research center where we're linking to the NDI to get longitudinal. Currently, the STS database for adult cardiac looks at 30-day outcomes, 30-day mortality, considered to be operative mortality, to look at a more longitudinal picture, we are linking with the NDI, and in the process of doing that, we should have some results soon that provide much more longitudinal data on mortality mortality. We capture risk factors. This is where you'll find most of the risk model variables. Typical things that we capture are related to cardiac disease, diabetes, hypertension, endocarditis, smoking, lung disease, illicit drug use. We did kind of we redid this section a little bit, and we now want to know, was that patient did that patient use illicit drugs within 1 year, and if so, was there a 30-day prior to procedure use? We're looking at that a little bit more closely related to the opioid epidemic, alcohol use, liver disease. Pretty much all your typical CV type of risk factors we capture. Cerebrovascular disease, prior CVAs and TIAs, and then carotid stenosis, of course. We look at prior carotid artery surgery or stenting, and that is also has an associated risk with it, increased risk. Look at your common labs. We do collect BNP. We do not collect pro-BNP. BNP is not used in any of the risk models, but we do collect that just because there is association with increased, heart failure with the elevated with elevated BNPs. The one area that would be great if we could collect more data on, which we know has an impact on outcomes or is a good predictor of poor outcomes, is the 5-meter walk test. Unfortunately, this is very difficult for sites to operationalize at their facilities, and it would be great if we could get more data on this, because we know how this plays such a factor in how that patient is going to do after surgery. Right now, we don't have enough data to include it in our risk models, even though we realize the importance of it. We started collecting COVID-19 fields in, I believe it was either at the end of March or the very beginning of April. This will be our first analysis with COVID-19 data, so we'll be able to look at that a little bit further and see how these patients, if they truly are having worse outcomes, which we are hearing that they are, and the surgeon leadership at the STS for the Adult Cardiac Task Force will be looking at what we need to do to either remove these patients from analysis so they don't count towards the mortality, or what types of mitigating steps we can do so they don't impact sites' outcomes. And then we get into the previous cardiac interventions, which of course any previous cardiac surgery will have an impact on the risk of the current procedure. Look at previous valve procedures, and of course previous stenting, and then other cardiac interventions, including ablations or procedures on the aorta, previous ECMOs, previous transplants, previous VADs. And then we get into the preoperative cardiac status. Dr. Kurtai, I'm going to stop here just for a second and see if you have any questions, or if the speed is okay for you.
I think the speed is okay for us, and we have a couple of questions, but I guess we could just, if it's okay with you, Carol, we could just wait until the end just to make sure that we kind of don't disrupt the process, and then we can take those questions on at the end.
Okay, very good. The next section we have here is the preoperative cardiac status. So we look at the patient, we're looking at the current status of that patient right when they're entering the OR, and then we're looking at what happened to that patient, in recent history. So we want to know about prior MIs, and when that prior MI was. Of course, patients who had MIs more close to the time of surgery are at an increased risk. We look at the primary coronary symptoms leading up to surgery. This is for coronary symptoms, so not related to valve procedures. And then we look at heart failure. One thing that was interesting in this version that we saw mainly with mitral valve cases is we have sites who capture, or surgeons who like to dictate out the NYHA classification for functional. This is related to functional heart failure, not so much the degenerative, I guess you would say. I don't know if that's the right term or not. But what they're looking for is the NYHA classification on all patients, not just heart failure patients, specifically because of the mitral valve patients who do not truly have heart failure, but have the symptoms presenting as such. So we're collecting that information a little bit differently in this version. We capture cardiogenic shock and resuscitation. These patients are not removed from analysis. They are, the increased risk is applied to the risk models. So if your patient has cardiogenic shock and they had to be resuscitated, that patient is going to have a worse than expected, their O to E ratio, the expected on that O to E ratio is going to be worse than somebody who did not have either of these going into the OR. So even if that patient has a bad outcome, the risk is mitigated through the risk modeling, and it's so and this is taken into account when they do that calculation. So your O to E would be closer to 1, which means that their outcome was more than closer to expected, even though they had these two terrible things prior to going into the OR. Cardiac arrhythmias we capture. And then the patients who go in, who are in AFib at the time of OR entry, they would not count as a postoperative complication if they went into AFib after surgery. Patients who are not in AFib at the time of surgery, even if they had a recent history of AFib and they were paroxysmal recent AFib, and they were not in AFib at the time of OR entry, developed AFib after surgery, they would count as a postoperative complication, but that risk is less because of the timing of their pre-procedural AFib. We capture preoperative medications. Of course, the usual ASARBs, amiodarone, beta blockers, calcium channel blockers, nitrates, anti-anginal, the ADP inhibitors, aspirin glycoproteins, 2B and 3A. And then any type of IV or sub-Q anticoagulants. So Lovenox or your regular heparin. And then, of course, Coumadin. And we were collecting DOACs and I forget what the other field was, but they could have both been captured as in this field. So we got rid of the other one and now we just collect DOACs. And then we have the inotropes and lipid lowering and steroids. And then we get into the hemodynamic. This is still the preoperative section. We want to know if a cath was done. If a cath was done, what date was it done? And then we ask separately regarding known disease, known CAD. And once a vessel is considered diseased, even if it's stented down to 0, we still count that vessel as being diseased. So it still plays into the risk of that patient going into surgery. We look at the number of diseased vessels and then also the previous procedures, if they had a cath or not, or a stented vessel. We capture left main stenosis greater than 50%. In the previous version, we captured all the different vessels. Now we capture the branch systems. So we had the LAD, the RAMOS, the CIRC, and the RCA distributions. What we're looking for here is if it's greater than 50%. New guidelines came out that were, I think, co-sponsored by the STS, the ACC, AHA, and I don't know if SCA was involved or not. But what they said is that a vessel is considered diseased when it's greater or equal to 70%. For purposes of our database and the reality that we don't perform surgery on vessels if they're only over 70%, we still capture the 50 to 69% and still call that diseased. But we are capturing greater than 70 to see the difference in those vessels, in those procedures and the outcomes of the patients. And then we capture typical cath or TEE or echo information with the EFs and if the dimensions are available, the PA pressures. And then we look at the valves and regarding regurgitation, stenosis, type of level of stenosis. And then if we have the hemodynamic data available, we look at valve area and mean gradient and aortic jet velocity if those are available. We also look at aortic valve disease etiology, which is, they're all listed here. And then we do the same for each valve. So we look at mitral. Mitral, we got a little fancy with the mitral disease etiology. 2 versions ago, we decided that we would collect Carpentier classification. The previous version, we decided we weren't getting good data on the Carpentier classification, so we broke it down by lesion types. We then, in this current version, we decided that we would capture both and see if we could make better sense of the data and get better, more complete data. So we capture Carpentier classification on the left, and then we capture the lesions that are associated lesions with that classification. So for example, if a patient has a normal leaflet mobility, but they have endocarditis, we would call that a class 1 and capture endocarditis of the native valve. So we started doing that in this version, and so far it's been working out pretty good. I haven't had too much feedback from the data managers about difficulty with this. We do monthly calls with the data managers to make sure that if they, actually twice monthly calls with the data managers to provide education and to answer questions regarding the data collection if they're having any issues. We try to educate on that and address their concerns. So this is one area I haven't seen questions come through yet. The tricuspid section, we have this pretty much same information regarding regurgitation, stenosis, and then the type of disease and the tricuspid diameter. And then the pulmonic valve, we are pretty much doing the same thing here. And it gets, this is a little, each valve we go down, it seems to get a little bit less of the information we want. So tricuspid and pulmonic are always left in the dark, but that's the, and then we get into the operative section. And when we worked through the upgrade with this operative section, we worked with our perfusionists, some from the Perform registry, a couple from the different perfusion societies or groups. And then, of course, the SCA helped with this section in major capacity. So in addition to our STS surgeons. So we worked through this, and it seems we capture, the STS risk score. This is a STS risk calculator that's available online that will give you a number associated, a percent number for the different endpoints, predicting a postoperative renal failure or postoperative stroke, mortality, prolonged intubation, a couple other endpoints. So we ask that the risk calculator is performed on all patients going into the operating room. It's not, but we collect that data just to assess it. This is where that information is collected. It's also one of the NQF measures that we can report for physicians. The incidence, the definition for incidence is into the same space. So a thoracic aorta for the first procedure, and then the patient goes in for a CAB, that would be the first cardiovascular surgery. If the patient was having an aortic root or an ascending aorta and then previously had a thoracic aorta, that would be the first re-op cardiovascular surgery. So we look at the space to calculate incidence. For status, we look at elective, urgent, emergent, and emergent salvage. The risk is there's associated risk with each of these levels. So because it's an emergent salvage, it is not removed from analysis. We do analyze that case, but there is a significant increased risk with emergent salvage cases compared to emergent or urgent. One thing that we did different in this version is that we started collecting emergent salvage reasons, because we were finding that most of the failed TAVR cases were actually turned into salvage cases, maybe because of an annular disruption or a device malposition, but usually it was the annular disruption that would turn that case into a salvage case, and we were not collecting data on that. So we added a couple more choices here, and we are now collecting the emergent salvage reason. We capture approach, and then if the approach was converted, if it was a robotic case, and then the typical procedures are, we capture all procedures that are performed by a CV surgeon who is listed on our consent or on our agreement. We capture bypasses, the aorta procedures, valve procedures, mechanical assist device procedures, and then other cardiac procedures and AFib procedures. We'll get into these more in detail as we scroll through the rest of the sections. I just want to mention here on the aorta procedures, we do capture this, and we have an extensive section that we capture aorta procedure information on. They are not analyzed at this time, but our quality metrics task force is in the process of building risk models for the aorta procedures. So these sections will open up the sections below for the appropriate procedures. We capture CPT codes if the site chooses to collect those, and then we look at OR entry, exit, the anesthesia section, incision start and stop time. We look at the antibiotic selection and timing and discontinuation. Those are carried over from the skip measure. We look, and then we get into the temperature section, and this is where it got kind of interesting here. So we capture the temperature that, this is the lowest lowest temperature of the patient during the procedure from, I believe, OR entry to OR exit, and we look at the source. We instruct data managers to be consistent in the source, and I believe that we prefer that this oxygenated arterial outlet blood is probably the most accurate, but we prefer that sites are consistent in where they're collecting throughout their form and throughout all their patients where they're collecting their temperatures. So we aren't, the sites aren't comparing things inappropriately. We capture hemoglobin hematocrit and the highest glucose, lowest hemoglobin hematocrit and highest glucose. And then we capture perfusion strategy. We added in left heart bypass for the aorta cases. And then we get into the circ arrest section, and of course the cannulation sites. We get into the circ arrest section, and we look at the lowest hematocrit, and then the circ arrest time without perfusion, or if there was cerebral perfusion, and if there was, then the timing for that. We then, if the patient was under circ arrest, we look at the total time, but we also look at the cooling time prior to circ arrest. So this was the time that cooling was initiated to circ arrest, and we look at those times because of the increased association with stroke postoperatively. Of course, we look at cross-clamp time and cardioplegia, and then blood products, clotting factors, and then we get into the intra-op TEE performed post-procedure. We get more in detail in the anesthesia section regarding the post-procedure TEE. And this is patients off a bypass before they leave the OR. And then if the patient was followed by a planned PCI. On the coronaries, we have each section then is broken down. The coronary bypass section, we capture internal mammary. This of course is used for NQF measure reporting. What's also interesting is that we are collecting the distal anastomoses with arterial conduits, and we're hoping that in the future we can do some type of reporting related to the number of arterial conduits used because of the improved blood flow that arterial conduits deliver. So we are looking more closely at that. And then of course, venous conduits, and we collect the prep time. This goes into the payments. So we look at that as well for harvest for the prep time. And then we collect information on what was done for the CABG, where the proximal, the distal sites were, what type of conduit was used, and what type of distal position, and if endarterectomy was performed. And then we get into the valve section. The valve section, first we start with, of course, with the explant. And we do capture if it was a leaflet clip. That was something new that we added in related to the mitral clips. And then transcatheter valve and valve with prosthetic valve. We're capturing those now. And then the explant etiology. We have 3 spots for explanted valves. I've only ever seen it once so far, but I guess it happens. The aortic valve without concomitant aorta procedure. So if this is just straight aortic valve, we capture information on that. If it's done in conjunction with the aorta procedure, either a Bentall procedure or they do an aorta and then, or they do an aortic valve and then maybe an arch or something like that, those procedures are captured in the aorta section. So we'll get there in a second. For the aortic valve section, we capture what was performed, a repair, a replacement. TAVR cases are excluded from analysis. So if it's a transcatheter valve replacement, we do not look at those for analysis. Some sites do double capture those between this registry and the TVT registry. And that's totally fine, but the analysis is done in the TVT registry on those cases. We look at the repair reconstruction, and these are select all that apply. So if more than one thing is done, we capture that. And then we look at prosthetic valve interventions. And we capture all of this more granular data. If they did a modified Reed or a Yakub, we capture that, and then what device was implanted. Mitral valve procedures, a similar format. We do the repair. Again, the transcatheter valves are not analyzed. We capture the repair section, the replacements. And then we do the surgical prosthetic valve intervention. Let's see what else we got here. And then the implant types and the implant models. The tricuspid is similar. Again, it gets smaller as we go down. The poor tricuspid and pulmonic valves always get left out. The repair, replacement, surgical prosthetic valve intervention, what type of implant was done if something was implanted. And then the pulmonic valve. We capture mechanical assist devices. We capture temporary assist devices go into the registry if they're done in conjunction with a index procedure. We do not capture all ECMOs. We capture them if during the stay the patient had an ECMO and then had another procedure that we analyzed, which would be a CABG or a CABG valve or a valve. We added this new field in related to 5.0 liter flow for Impellas. Currently, Impellas are considered to be mechanical temporary assist devices. We know that 5.0s are usually used on a more permanent long-term basis, but we don't have enough data to analyze it yet to say if the risk is calculated correctly or not. So we are looking at that. It looked like the risk was under-calculating, but we are looking at that, or over-calculating, I'm sorry. We are looking at that though, just to confirm. And then we have temporary assist devices, and then VADs. We also run the Intermax PDMAX registry, which captures all FDA-approved VADs, long-term VADs. But if a VAD was done during an index procedure, we are capturing that also in the ACSD database. And then just when it was put in and what was put in, and if any VADs were explanted. The other cardiac procedures we collect are listed here. And there was not a whole lot of change. We do capture associated adult congenital procedures. And then we also capture the atrial fibrillation procedures. LAAs, left atrial appendage obliterations, these will keep cases in the analyzed procedure. If the lesion location is epicardial, if it's intracardiac, it usually removes it unless it's a mitral valve procedure. Lesions documented, these are for mazes, so we capture that. And then we also capture the convergent procedure. We just started capturing that this go round. When we get to the aorta section, the aorta section, and then the aortic root procedure section. And we capture history first. We are looking at genetic history and a familial history. So we are looking at that, and we'll see what the data shows in our quality metrics task force, how that plays into the risk of these patients. We know that there's a definite association there. We look at previous procedures and if the current procedure has a related endo leak. And then we look at trauma and infection. Our main cases that we collect are, of course, aneurysm and dissection. And then the aneurysm, etiology, type, rupture, location of the maximum diameter. And then the aneurysm is when did the aneurysm occur? Was the dissection on the onset? No. And then the locations of the dissection, the primary, if there was distal, if there was primary proximal or distal extent, and how far it extended. We also capture, we're using zone systems here, but we just added back in the Stanford classification to compare how we're doing capturing the zones compared to the Stanford classification definitions. And then we're capturing if this is 30 days, if the patient's post-TEVAR or if they had 30 days post-TAVR, and then any other cath procedure. We look at malperfusion and extremity or sensory deficit, and then if there was a rupture. If there was a rupture contained or in one where it was at. And then we get into other anatomical location. We look at the root or arch anomalies or the ascending aorta for anything that might increase the risk for procedures. And we look at measurements for the largest diameter of the treated segment. And then specifically for endovascular cases, we look at the largest diameter proximal and largest diameter distal to the treated zones. Then we get into the intervention section. We look at the aortic valve and root procedures first. This aortic valve section is duplicated from the other aortic valve section. And then we get into the root procedure section where we're looking at bent holes and things like that. We have valve sparing root procedures, David Jacobs and Florida sleeves that we're capturing, and then how the coronaries were reimplanted, and then major root reconstruction debridement. We then get into the ascending and arch procedures, and we're looking at proximal distal locations, any extents. We're looking at elephants or frozen elephant trunks, and how the arch branches were reimplanted if they were reimplanted. We don't capture if they were stented or not. We do capture if they are reimplanted. We look at other open surgical descending thoracic or thoraco-abdominal procedures, and then how the visceral vessels were managed. And then we also capture the endovascular procedures, and we look at access, if it was percutaneous, proximal and distal landing zones, and that's why we look at the largest diameter proximal and distal to the treated zone to see if, look at measurements for the devices that were inserted. And then ascending TEVARs, we capture arch vessel management for the endovascular sections and visceral vessel management. And then we have the other endovascular procedural information. We look at dissections proximal to the entry tear, endo leaks at the end of the procedures if it was converted to open, unintended rupture, and anything else that was done if the patient had spinal drains placed, and any of IVUS was performed, any of these other informations they're capturing. The new one that we added was this endovascular balloon fenestration of the dissection flap. We captured the devices for this section. This is the first part is the aortic valve, and then we captured the aorta devices. We capture congenital defect repair for adults with congenital disease. And then we capture other non-cardiac, which is, of course, the endarterectomy, carotid endarterectomies, vascular or thoracic procedures. Most of these will remove it out of the analyzed case. I believe we'll have to check into that. I might be wrong. Never mind. Post-operative section. So first, we asked did the patient expire in the OR, and if the patient did not expire, then this section will open up. We added a new field in here, this peak post-operative creatinine within 48 hours of OR exit. This is, I guess, apparently some research has recently been published that shows that the patient's post-operative creatinine within 48 hours is a good indicator of that patient requiring long-term dialysis So we started capturing that field in this version to see if that's something that we need to be paying more attention to and managing better for patients on the whole. And then we also capture the peak post-operative creatinine level. Blood products used post-operatively. If the patient was extubated in the OR, total vent time is from OR exit to the initial vent extubation, and then additional vent hours. The total post-operative vent hours over 24 hours is considered prolonged ventilation, and that is one of the endpoints we look at for the risk models. We talk about ICU and if the patient had to be returned to the ICU, and then we look at the post-operative echo, and then post-operative events if they had a SSI or a DSWI. We capture that information. We just started capturing 90 days for deep sternal wound infections. If sites choose to follow their patients out that far, this goes with the CDC definition of deep sternal wound infections. So we may make this a more permanent field and require sites to capture that in the future. But right now, sites don't have the manpower to be capturing out to 90 days post-procedure for all of their cardiac surgery patients, so we have to wean them into it. And then anything else, if the patient had a re-op for bleed or tamponade or valve dysfunction, aortic reintervention, and any other reason for them to return to the OR, we look for sepsis, post-op stroke, encephalopathy, peripheral neurological disorders, pulmonary issues. That prolonged vent again is greater than 24 hours, and pneumonia. And these things listed here. We look for renal failure on patients who meet the reuse the rifle criteria for renal failure. And then vascular mechanical assist device related issues, aortic complications, anticoagulant bleeding events related to anticoagulants. We're capturing HIT and HITT, GI events and AFib. We capture if the patient was alive or dead at 30 days. And then if they were patients, we follow patients throughout their entire acute hospital care stay. So if they were transferred from hospital A after a procedure to hospital B for continuation of care, we follow that patient throughout that entire stay until they're discharged from the acute care hospital, capturing all of their post-operative outcomes. Because we're looking at the procedure and the associated poor outcomes with that, regardless of where that patient's care was delivered. Status at hospital discharge. Patients who are discharged to hospice are now included as a mortality, regardless of if they die past the 30 days post-op, because patients who are undergoing cardiac surgery shouldn't be discharged to hospice. So the surgeon leadership felt strong about counting these patients as a mortality. And then we captured, this is a new NQF screening. We're screening for illicit drug use, alcohol use, and tobacco use. And if the patient screened positive to any of those, then they must be counseled for the item that they screened positive for to code yes to this. It will be a new NQF measure. We look at antiplatelets, anticoagulants. And I'm going to scroll down here to the anesthesia section because we just have a few minutes left. I'm happy to go over, but I don't want to cut this anesthesia section short. So the anesthesia section here, we capture who the primary anesthesiologist was, the type of model that was used for the care team model for anesthesia. We look at if there was a CNRA or AA, and we look at the ratio for those. Again, this section is optional. It would be amazing if we could get more sites to participate in this, so we could look at these data in a broader aspect. We capture the baseline pain score, and then pre-induction blood pressure, heart rate, and if a pulmonary artery catheter was used, and what algorithm was used to guide transfusion. We look at anticoagulation prior to CPB, and if heparin was used, the dose, if that patient required FFPs or antithrombin 3s and the dose of that if heparin was used. We look at bivalirudin or atraban also for this section, and then viscoelastic testing used intra-op, the volatile agents, and when those agents were used. It's a select all that apply. We'll look at intra-op Versed and sufentanil, fentanyl, and Remi. We look at those, and then we look at the multimodal analgesics, OR entry to 24 hours post-op exit. So what we're looking for here is how was this patient's pain managed during the time that anesthesia is mainly responsible for managing that patient's pain, which is usually the 24 hours to the 24 hours post OR exit. And we're collecting these medications here. We capture the core temperature, and we instruct sites to be consistent with how they're capturing this in adult in the other operative section. And we're looking at core temp max during rewarming. So we want to know how what was the maximum temperature that patient was rewarmed to. We look at crystalloids by anesthesia, 5% albumin, 25% albumin, ANH, inhaled vasodilators, IV vasodilators, glucose stro, and intra-op insulin given. These are all the ways that you're managing your patients in the OR, and it's important to see if the way you're managing patients are improving or not improving the care and their outcomes. So it would be, it's really helpful to have this data to look at. We capture the intraoperative processed EEG and the postoperative, post-induction pre-incision TEE. A few things that we added in this upgrade is that we're looking at the left atrial size and left atrial superior inferior and left atrial medial lateral. So these aren't often dictated, but it would be great if we could start capturing this pieces of data. Ascending aorta assessed, we removed this out of the adult section, out of the other operative section. Anesthesia wanted to capture it, so we're capturing it here, and we want to know the diameter, the thickness, and any mobility. CPB used and how the ABGs were managed. These were new fields that were added into this. We're looking at how the ABGs were managed and how they were managed during cooling and rewarming. And then the arterial flow temperature measured and what the highest arterial outflow temperature was. Retrograde autologous priming of the CPB unit, total crystalloid by perfusion team, and then we collect the same, the 5% and 25% albumin by perfusion, hemofiltration, inotropes, and vasopressors if they were used. I'm sorry, if inotropes and vasopressors were used when the patient was weaned from CPB. Cell saver volume, protamine total dose, and then the postoperative procedure use of the intra-op TEE. We're collecting SAM and return to CPP for echo-related diagnosis. We clarified or added a few choices here. We have new wall motion abnormality, which is if there's a residual valvular leak, SAM, paravalvular leak, ventricular failure, other or unknown. And we had some clarification in our training manual that we used for the data managers and provided some education, I believe, on the difference between ventricular failure and new wall motion abnormality. And then we get into, this is additional TEE information, and then we get into the post-operative section. And these are all measurements of the patient in the PACU or ICU, and I believe we look at, I believe our timing is 1 hour upon admission to the ICU that we're looking at, INR, platelets, WBCs, hemoglobin, hematocrit, fibrinogen, lactate, and peak glucose is 18 to 24 hours after OR exit time. We're interested in the use of post-op propofol, other sedations, post-op delirium, and then the pain scores on post-op day 3 and pain score on discharge. So that's the end of this section, Dr. Kurtai. Sorry it took so long.
No, it did not. And Carol, as always, you've done an excellent job with taking us through the process and explaining, the thought process and the rationale behind collecting information within the surgery as well as the anesthesiology section of the database. We have a little time left for some questions. So I don't know, Carol, whether you can actually, and the other panelists, open up the Q&A section of Zoom, and we can just quickly basically go through some of those questions, then, just in maybe a sentence or two in terms of explaining what would be the response to those questions. And as you can tell, I already kind of formulated some responses to those questions, but I would love to hear, the input from the other panelists.
Sure, of course. Do you want to read them out loud, or would you like me to read them out loud?
Yeah, so you can go ahead with the first one and I will read out the second then.
Okay, this first one from Jessica here. Is that what we're doing?
Yes, please.
Okay. I mobilized resources, data team support to get Stanford contributing to ACSD anesthesia databases a few years ago because I thought it was the right thing to do, but also anticipating figuring out a meaningful and user-friendly way to use the database to improve care of our patients and or look more broadly at outcomes. I still believe it is the right thing to do, but I have not found any easy way to integrate it. Demonstration of a few methods of utilization beyond just data entry would be helpful. Thank you. It sounds like she's looking for both research and internal QI projects. And
yeah, that is correct, Carol. And basically, I also received an email from Jessica, and I'm happy to take offline, this discussion and basically highlight some of the opportunities how the database could be used at the local or kind of at the national level in terms of addressing some of these research types of questions or QI type of questions. So, and obviously, as you basically show that slide with our email addresses, I'm happy to answer any future questions that are kind of relevant to how the database could be actually used for research as well as QI purposes. And let me just quickly kind of jump to the next question. This is from Douglas Shook. Can the surgical and anesthesia databases be queried so anesthesia data can be related to outcomes? Are the anesthesia and surgical databases combined? So previously, the databases were not combined, but thanks to the team, the STS team and Robert Habib and his team, we combined the anesthesia and surgery sections from starting version 2.81 all the way to the current version. So yes, there is an opportunity to actually study some anesthesia related variables that are captured through the anesthesiology section of the database and study their potential impact on outcomes after cardiac surgery using data that is available, including outcome data in the cardiac surgery section of the database. Carol, the next one to you.
Sure. My large hospital, this is from Elizabeth Herrera. My large hospital employs 3 data extractors for STS who are manually extracting data for charts, even though we have Epic. They are not currently providing data for SCA because they are so overwhelmed by the surgery portion and are always about 3 months behind. I have asked Epic National if they could help, but my hospital is not interested. Is there a way to extract data by Epic in an easy way, or does everything need to be manually abstracted? So it does need to be, there are a few fields that we allow for automatic abstraction, but to ensure the integrity of the database at this time, related to the inconsistency within different EHR vendors doing definitions or having definitions not match across the whole nation, specifically for our risk factors, we cannot allow automatic abstraction of all of the factors at this time. There is work in progress, and we have talked with Epic in the past about working with them, but that didn't play out. So hopefully in the future, when we have things like SNOMED in place across, the entire nation, and everybody is on board with consistent definitions, we'll be able to do that better. The issue also comes in when we're looking at mapping in Epic, and every time Epic goes through an upgrade, their mapping changes, which could screw up the integrity of the data. So we're very cautious about doing that at this time. Miklos?
But nevertheless, Carol, basically, you and I discussed that before, that when we went through the upgrade, the 2020 upgrade process, that when these variables were selected and carried forward into the version 4.2, we also kept in mind that if there is an opportunity in the future for an electronic data capture, these variables would be easily or much more easily retrievable.
Yes, we've looked at that through all the variables in the database for this upgrade.
Absolutely. The next question is from Jacob Raphael. So he's asking whether basically the SCA can help with a centralized data use agreement. And this is something I'm happy to take offline and obviously follow up with the STS team as well as with the SCA leadership in order to see how we could actually help with this process in order to basically streamline and ease the process of doing research studies out from the database. Carol?
Okay, I think Elizabeth is saying thank you for the information. She seems it would be easier to do this abstraction at a smaller site versus a 1,200 case a year site, which is absolutely true. And we are interested in automating more aspects of the database. And I think we'll have more possibility with IQVIA as our data warehouse, because they do have experience in doing that with other databases.
The next question is from Yoshi. Did I miss a section for blood product administration, FFP, cryo, PPT, or platelets, I guess, and PRBCs? And Carol can actually quickly zoom in onto the section where basically that information is captured as intraoperative blood product administration, and also the type of blood product that was given to the patient.
Yeah, we capture that in two sections, in the operative section and in the some of it in the anesthesia section. This is the operative section where we capture this information. The neat thing with IQVIA is that sites who participate in the anesthesia section will have all, instead of, currently they're receiving two separate reports, one for the adult cardiac and one for the anesthesia, which comes out about 2 months later after the adult cardiac report comes out for some reason. When we have these reports available in IQVIA, which will be soon, all of the data will be available at the same time, and the anesthesiologist will be easily able to access the operative information that's contained in the operative adult cardiac section. So we do capture that here. It's in the operative section.
That's perfect. Thank you, Carol. So the next question is from Yepeng Huang. The issue with positive measurements by anesthesiologists is that we will not see patients after we drop off patients in ICU. Who will input these days discharge ICU data? Carol, would you like to address that?
So the data manager goes into the chart and pulls up this information in the record in the EHRs and pulls that out. I think that would answer that one.
Perfect. And the next question is from Peter Tua. Does the SCA contribute to thoracic database? This is something probably that occurs more at an individual level, as far as I know, but I'd like to actually ask Bruce to weigh in on that one. But at the SCA level, currently there is no ongoing initiative to contribute to the thoracic surgery database.
I believe that's true. I think on the other hand, number one, I think our anesthesia colleagues can encourage their institutions to contribute to that. And number two, if people in the SCA feel strongly that we should do that, they should contact Miklos and we can look into that. Does that make sense, Miklos?
Yeah, absolutely. So we are happy to basically collect any feedback from our SCA members and members of the different subcommittees and committees within the SCA. And if there is a strong desire to collect information or participate in the thoracic database, we would like to actually hear about that and take up on that initiative and follow through it.
I could take this next one. In the section of postoperative delirium, is there a time limit to the diagnosis? For example, first 72 hours or during the entire hospitalization. So what I've pulled up here is our training manual that all data managers have access to. It's updated on a monthly basis with any changes or questions we get in that would help provide clarity. For the postoperative delirium section, we have the time frame from OR exit to initial ICU discharge. So that's how that's the time frame for postoperative delirium.
That's perfect. Thank you, Carol. And then I have a final question, which is actually came through my phone. What is data density of all these fields, completion rates?
Sure. So we do have we did look at frequencies when we did the upgrade, Miklos, and we any field I can be happy to share that, but I have to go into a different computer to pull it up. Any field that had a low frequency, we looked at that and made a decision about if it was reasonable to capture, and if it was reasonable to capture, was there a reason why the frequency was low? Was it related to poor data manager understanding of what was expected, or were we asking the data managers to capture something that was really difficult to locate in the chart, or that they couldn't make sense of? So we would look at that and either change how we were capturing it or change what we were capturing it to get to the same endpoint for those questions. But yes, we do have frequencies for the last version that we used for this upgrade.
That's excellent. Thank you very much. And this is basically where we would like to conclude this webinar in the interest of time. Everybody to Carrie and Jim bring us the participate in and full discussion. And I'd wish everybody a good night and for joining our webinar.
Thank you, Dr. Kurtai, thank you, Dr. Bolin, for having me present. I really appreciate it, and I'm happy to answer any questions if anybody has them after the webinar.
Thank you, Carol.
Thank you. Take care, everybody. Have a great night.
Good night, Carol. Good night, everybody. Thank you.
Everyone for joining.
Okay, have a great night.